but also keep it.
All right, ladies and gentlemen, we're going to get started here. We want to thank you so much for coming down here. We want to be respectful of your time, so we're going to try to end this right at 7, if not 7:15. But we're going to get started. So once again, thank you so much for coming. You're probably asking, okay, we know the title of the panel, but who the heck's hosting it? So my name's Varun. I'm a part of the student chapter here called Universities Allied for Essential Medicines. And we're a student-run organization dedicated to advocating for access to essential medicines around the world, especially lower and middle-income countries, but also exclusive patent licensing, non-exclusive patent licensing, and how can we disseminate technologies that serve the public interest. And so while we were discussing about what kind of panel we could have this month, one of the things that came up on our radar was the fact of Canada creating a mandatory reporting license for pharmaceutical companies to report drug shortages in Canada. And for us, that was really important because it got us thinking about access to medicines issues right here at home. So about 1 in 10 Canadians can't afford their prescription medications. 2 million of us incur over $1,000 per year in household expenses for prescription drugs. There are $14 billion that could be saved in our healthcare system if we decided to spend the same amount of money on pharmaceuticals as we did UK. So, you know, these types of questions intrigued us, and we said, you know, what is the Canadian drug shortage crisis about? Where is it coming from? What can we do about it? How does it involve us? So I'm really happy to see all of you guys here. I see students, I see community members, professors, teachers. It's just great to see all of us here together so we can discuss these issues. And so what's going to happen tonight is that we're going to have 2 speakers that are going to come in, and then we're going to take a 5-minute break, and we're going to come back and we're going to have a 45-minute Q&A discussion on our panel. So I'm going to introduce the first speaker here. Our first speaker tonight is the distinguished Hanna Chair of History of Medicine here at Queen's, a professor of medicine and a practicing physician specializing in hematology. She's a former president of both the American Association for the History of Medicine and the Canadian Society for the History of Medicine, the author or editor of 8 books, and holds several awards for her research, teaching, and service. She's also the webmaster of www.canadadrugshortage.com. So please join me in warmly welcoming Dr. Jacalyn Duffin.
Can you hear me? Sound is a bit of a problem in this room. Well, thank you so much for being here, and thank you, Varun, for the lovely introduction. I'm really honored to be part of this, and as you heard, I'm a historian as well as a hematologist, and I'm going to tell you about this problem historically from my own perspective, and how I first heard about it, and why I came to start that website that Varun has mentioned. And it's something that came to me in my work as a doctor working in cancer care, but it's something I'm exploring using the tools of history in doing it. So it goes back to a patient whom I was looking after in the cancer clinic, who was a 51-year-old widow with 2 daughters who were high school age, and she had metastatic breast cancer and was on chemotherapy. And she came to the clinic and told me that she wanted to stop taking her chemo because she couldn't get the drug that controlled her nausea. And she tried a whole bunch of different drugs, and there was one that worked for her, and it was prochlorperazine, otherwise known as Stemetil. And I said, what? Because that drug is really old, and it has been around as long as I have. And I couldn't imagine why she couldn't get it, and I immediately called up the pharmacist. And the pharmacist was not too surprised to hear from me, and he said in dulcet tones, as I was trying to give him a hard time, how dare you not have Stemetil in your pharmacy? And he said, well, there is no Stemetil in all of Kingston, but you can prescribe. And then he named a really expensive new drug. So I immediately smelled a rat. Can you guess? Yeah, that was one of them. What's the rat? I was worried that Big Pharma was somehow buying up the license to sell the cheap older drugs and then just casually not making them anymore, which would then force us to prescribe all the expensive new drugs. That was, I would have to say, a fantasy at that moment. It was a hypothesis, but it is now one of many causes. In my life as a historian, I got interested in where this problem came from. I was curious about whether it was new or old. It turns out that we've had drug shortages for a long time, but we haven't had them with the frequency, the intensity, or the number since about 2008-9. And in trying to keep track of this information, by the summer of 2011, so 6 months later, I was completely confused. And I started my website partly to keep track of all the information I was finding, and also to disseminate it, to make it available to anyone who was interested. And at my website, there is a blog portion called Patient Stories, where people can write to me and tell me about their stories. And it's grown slowly, actually quite slowly, over the years. But these are the drugs that are blogged about at my website. And for those of you in medical school or medical practice, you'll recognize that it's just about anything can be in short supply. There is one unifying feature to all of them. They're all generic drugs. A generic drug is an older drug that is off patent. In other words, the original inventor has enjoyed patent protection for a certain length of time, and then it is fair game for anyone else to start making it. And usually at that point, the prices fall. So generic drugs are not bad because they're old. Some of them are actually really reliable and quite good, but they tend to be cheap, and the profit margins are very narrow. So if you're making them, you have to make and sell lots of them in order to make a profit. What I also discovered is that it's a global problem, and I'm tracking it right now in 45 different countries, and I think it would be a lot more if my language skills were better than they are. But I added Ukraine today to the website because drugs are going in short supply in Ukraine, and you can imagine all the reasons why that might be. But what journalists are always asking me every time I end up talking to a journalist is, but what is the cause? What is the cause? And in fact, there are now 14 hypotheses at my website, and they're bundled a bit here in this slide, and I don't propose to go through them all. My original suspicion about the pharma industry has not been taken off the table, but a whole lot of other possibilities have come along. Some of them have to do with manufacturing problems. The industry itself will blame the American FDA and Health Canada for causing slowdowns because when they find an irregularity in the production of a drug, they make the company stop making that drug in order to clean up the problem. And we want them to do that. We're not opposed to them doing that. But as a result, if it's a just-in-time delivery and there's only so many, suddenly there can be a short supply, especially when there's only one manufacturer of some of these drugs. Some have said the generic prices are too low, so people are just getting out of the industry, and we have seen that in certain cases. There's a whole group in the United States who want to blame the middle managers or group purchasing organizations, which we can talk about in questions if you like. Plus the fact that we don't have any drug industry here. We have a few companies that belong to Canada, but even the Canadian companies license factories in other countries where the wages are lower and they don't have to pay for benefits so that they can save on the costs of manufacturing. So we can't really do much to compensate from here. Pharmacists, I take off the table and sometimes I put them back. Pharmacists are actually on the front line, and they're the ones dealing with the patients who are crying and upset, and they've been really good about sharing the drugs between their institutions. And in fact, the Canadian Pharmacists Association has done 2 very good surveys about the extent of the problem, and nobody else has in this country. So my website gets a lot of hits when I'm on TV or interviewed, and this is a Google counter on my website, and you can see that when I'm on the current, that was the maximum number of hits I ever got in any day, much more than being on Newsworld, which is really interesting. Radio has a bigger effect. And in this heat of this moment, when I was on the radio and did a few appearances, and this was all because there was a specific crisis in early 2012, the editor of the CMAJ was driving to work and heard me on the radio, and so for I think the first time ever in my life, I got called by the editor of the CMAJ, would I please write an article? And it got published. Like that. Normally never happens. And it was a 1-page article summarizing the history of the drug shortage as we know it now, published in May 2012. Things are not much different than when that article was published, and you'll see what an effect I'm having. It's been cited exactly 3 times in the literature, which is like not at all. So then they want to know, what's the harm? What's the harm? And they want to know who died and who suffers and who pays. There are people who've died because of the drug shortage, but we don't write that on the death certificate. People die of a disease. So nobody is really counting the actual mortality impact of the drug shortage. People suffer, and there's examples of that at my website, but for example, who pays? Drugs are taken by the elderly, they're paid for by the taxpayer. People in hospital, paid for by the taxpayer. People on welfare, paid for by the taxpayer. The working poor that Varun was referring to earlier, they don't take their medicines. Sometimes they can't afford it, so they stop taking their medicines, either because they can't afford it or because the meds aren't available. They end up in hospital. That is paid for by the taxpayer. And then the working well, people who are lucky to have drug plans, like we who work at Queen's, will find that their premiums rise. And in fact, that has happened since I started tracking this problem. So the point is, in Canada, everyone should care, especially the government, because the government is taking the taxpayer money for this problem. The government is talking about healthcare costs and how they have to be under control, and not solving the drug shortage problem will simply add to healthcare costs. So what has the government been saying? Okay. Well, for the first little while, they said nothing. When it started, we, in our cancer clinic, 9 of us, wrote a letter to the ministers of health, federal and provincial, and said, hello, this is going on, what do you think? And we got really nebbish replies, basically no replies. From the Ontario government, it was sort of not my fault, not my problem. The federal government didn't reply for quite a few months. It was from November until the election was called in the following year. And then we got a boilerplate letter saying, thank you for your letter, your opinions matter to us, vote for me. But finally, when that crisis happened in 2012, because there had been a problem with the Sandoz plant in Boucherville, there was an emergency debate in the House of Commons. And the Minister of Health, who was Leona Aglukkaq, arrived for this debate, which took place at night. It went on till 1 o'clock in the morning. And she walked in. She spoke for her 20 minutes, and then she walked out. She didn't stay for the rest of the debate. And to my amazement, she blamed the global drug shortage problem on the provinces. She said that the Canadian provinces were guilty. They are the people looking after health, and they had failed to diversify their supply chain. And that was why we were having drug shortages. How can you diversify your supply chain if there's only one manufacturer? Who licenses the drugs in Canada? Health Canada. So if anyone knows where there are drugs that are vulnerable to that kind of shortage with one manufacturer, it is Leona Aglukkaq, whose agency is licensing the drugs. It was really distressing. On the question of should there be mandatory reporting, she said no, there should be only voluntary reporting, and she announced her website. In fact, they got press releases and media coverage of the same website multiple times over 3 years, and that no mandatory reporting was not allowed. We'll come back to that. Because of this little crisis, the Health Committee spent 3 days in hearings about the drug shortage, and Kelly Leach, who is a minister in the government, took on John Haggie, who was the president of the CMA, a surgeon, and quite concerned about it. And Dr. Leach is also a surgeon, and she said to John Haggie, you're a surgeon, I'm a surgeon. When I run into a problem with the drug in my operating room, I don't call the Minister of Health. I just call up my pharmacist and solve it. In other words, she accused the representative of the physicians of the nation of whining, and that it would be inappropriate for the government to have any role. Following those meetings, they released something called the Multi-Stakeholder Toolkit and promised to have continuing meetings. There have been no more meetings of the multi-stakeholder group, and the multi-stakeholder group is listed there, and it's a rather skewed representation of healthcare providers and drug companies. We want to have the drug companies involved, and then nothing for a long time until last May, when public consultations took place, and I was invited because of the website to be one of the people interviewed on this, and I spent 2 hours on the phone with Health Canada. They kept asking me questions over and over again, which were all around the issue of should it be mandatory to report a forthcoming shortage or not. And they kept coming back to this issue over and over again, worried, what would be the harm? No harm. No harm in reporting her early. There might be a little bit of a problem for the drug company who wants to keep their stakeholders happy, who wants to keep the dividends high in revealing that a drug is going to go missing in 6 months. But as for the health of Canadians, no harm from that kind of information. And there was a little bit of a leak in September 2014 that they would go mandatory. Then it was taken away. And it wasn't until, you may have noticed it, in February when Rona Ambrose finally announced that there would be mandatory reporting. But in those consultations, we kept pointing out that mandatory reporting is fine, but it's not going to solve the situation. It's a tiny little step. It gives us useful information because it's not looking for the cause of the shortage. And once again, the same old website got announced. That was really very interesting. And around that time, I got more media coverage in February, and I got more hits, and then it was totally back to usual with people ignoring me. I think I was down to a new low 5 days later. And today, this is the Health Canada Drug Shortage Database today, which never summarizes, doesn't give us monthly accounting of the shortages, doesn't even give us annual accounting of the shortages, doesn't tell us the average delays. And look at a whole bunch of drugs just appeared today. There's March 18, 2015. When is the start date of the shortage? March 18, 2015. When was it reported? March 18, 2015. Nothing has happened. So, solutions. And I know that my co-panelists will be talking about this, and that's what you really care about. In fact, Varun and Sean told me, we want to know how to fix it. Okay. So advanced tracking is a feeble start, but it's not going to solve the problem. We need to know more about our drug supply, because a lot of it has to do with business decisions. We need to involve the Ministry of Health, yes, but we need to involve the Minister of Industry, Minister of Foreign Affairs, Ministers of Finance, and their counterparts in all the other countries that are affected by this problem, because this is a global problem, and I don't think it started here in Canada. So I'm disappointed that Canada doesn't show some leadership in this direction and start talking internationally, either through WTO or World Health Organization. We have to understand what's wrong with us that we don't just start making the missing drugs ourselves. If we're having trouble getting them from these other companies, why don't we make PharmaCan? Aside from a PharmaCare plan, why don't we have a national pharmaceutical industry? What is wrong with the country that some entrepreneur hasn't gotten their act together to start making drugs here? And finally, the big and most important solution is to find the cause. To figure out through that labyrinth of all the possible causes. Because in medicine, first we diagnose and then we treat. Thank you. Is that okay?
That's all good.
10 minutes?
Awesome. Thank you so much, Dr. Duffin. So, our second speaker tonight is an associate professor of the Department of Public Health Sciences here at Queen's. She's the pharmacist who brings over 15 years of clinical practice experience to her research, including cardiology, internal medicine, infectious diseases, and has published widely on the impact of clinical trial methodologies and the impact of drugs on population health. I know her from her teaching section on clinical trials in DDHT 460, and so I can confidently say that if you ever have the opportunity to take the course, you should do it. So please welcome Dr. Linda Levésque.
Thank you. Well, anyone who knows Dr. Jacalyn Duffin knows that it's always a bad idea to present after her, because no one can ever do her presentation justice, because she sets the bar so high. What I want to do essentially is take 5-10 minutes of your time to just give you along the same lines but a different perspective. So my concern about this very real, very important debate is that often in the media what I hear is this concern over drug shortages get extended to the concept of drug access, generically speaking. And there's often call for quicker or greater access to drugs in Canada. There's often complaints that the regulatory process is too slow here, and that somehow Canadians are being harmed by the fact that it takes longer for us to make decisions about drugs. And the angle I'd like to take with my presentation essentially is, let's make sure that the drug shortage concern and real issue doesn't become a, hey, we want everything as a free-for-all very quickly, no questions asked. So I'm going to present you some information along those lines. And essentially, what I want to do is focus on 4 basic concepts in terms of where I come from as a drug safety and vaccine safety researcher. One is that the context within which we're making decisions about this and related drug access issue is one of increased drug consumption. And I'll present you some statistics about the good and the bad of that increased consumption. The fact that we have a problem of marginal benefits for new drugs, diminishing returns, the dangers that we get with fast tracking of drug approval process, which is something that there's been a lot of push for in the media and by consumer groups, often backed by the industry. And finally, the dangers and the pitfall that go along with aggressive marketing of pharmaceuticals in Canada. So we know that drug consumption has gone up exponentially in Canada. These statistics go, and in 2008, I was looking at the Patent and Medicines Pricing Review Board website this morning to look at more recent updates, and we've surpassed the consumptions that was predicted in 2008. And so drug usage is an all-time high. Of course, there are good reasons and there are bad reasons for that. The population is growing, the population is aging. Therefore, the incidence of chronic disease is going up. We're going to need more medication for that. But when these factors are taken into account, and these are the good reasons for drug use increases of consumption to go up, the factors that are disconcerting to me is the fact that taking those factors aside, the next most likely reason, or the greatest reason drug consumption is increasing, is because of the availability of new patented medications that come on the market, and the fact that there's actually increasing volumes in prescribing beyond, and I'll present some data on that, beyond just the aging of the population and the increasing burden of chronic diseases. And then finally, that there's a very aggressive approach on the industry's perspective to shift physician prescribing away from these old traditional, we know them well, work well, inexpensive medication, towards the newer, glitzy medications that offer us very little in the way of therapeutic benefit. Indeed, the most recent statistics show us, and these are borne by more recent statistics as well, that next to cost and hospitalization, cost and medication usage is the second greatest component of healthcare expenditures. And I actually would not be surprised if by the end of this decade, it actually surpassed hospital care. Because most of the new therapies coming on the market now, especially the ones that work on the immune system, the immunomodulators, and some of the new chemotherapy agents, are astronomical prices. The problem is not one of rising drug costs per se. People will often say, well, of course we're spending more because things cost more over time. This slide shows you what the average drug cost is, taking into consumer index into account. So it's, in other words, just looking at the inflation of drug costs. And you can see that over these 2 or 3 decades of data I'm showing you, where drug consumption has more than tripled in Canada, the actual attributable fraction of that to drug cost increases is only 1%. So on average, consumption has gone up by 10% per year over the last 3 decades, but drug costs per se have only gone up 1%. So it's really an issue of we're just using more and more of the expensive things. The problem of overconsumption or high consumption of drug is not isolated to Canada. It's one that affects many countries globally, including in Europe. So here's data on Scotland that shows you what's happened to consumption over a space of a decade and a half, looking at the number of drugs that people take. And you can see that the number of people that are taking 5 drugs or more has actually doubled in that amount of time. Now again, some of this is explainable and understandable. Aging population, increasing prevalence of chronic diseases, we're going to need more things. But we know it's not all attributable to that. The problem of polypharmacy, as we call it, we also have statistics from Sweden as well. So it's a global problem. But what's interesting is, when we compare Canada's consumption to other countries, Canada is only second in consumption to the United States. So, although yes, globally drug consumption has increased, we seem to have a ravenous appetite for drugs in Canada, and we're only surpassed by the United States. Why is that a concern? Well, it's a concern on multiple levels. It's a concern partially because we know, so there's an agency in Canada called PMPRB, the Patent and Medicines Pricing Review Board. It was actually created in 1988-89 after the passing of Bill C-22 by the Mulroney government, which gave extended patent protection to medications in Canada. And part of that was to provide Canadians protection against price gouging. This board was put into effect, and their job essentially is to look at the cost of new medicines as they come onto the market, and to make sure that Canadians are getting fair market value compared to 7 other developed countries in Canada, United States and then European. What's interesting is that one of the things they do, and they've done that every year since they've been in existence, And they used to put out this nice chart in their annual report that now gets buried in an appendix in a table, very complicated table. And I think it's because it's perhaps a bit too controversial. The data shows us consistently, since the PRB has been tracking medicines, one of the things they do is they qualify medications on the basis of the therapeutic benefit they give us. What advancement, medically speaking, are these new drugs making? And guess what? Consistently, year after year, for the last 30 years, 95% of drugs that are marketed in this country provide little to no therapeutic benefit. So we have to be careful that when we're advocating for increased use, increased access, and faster access, that we understand that we're not getting access to increased benefits most of the time. There is, on average in this country, 1 to 2 new therapeutic breakthroughs a year. The rest is just a derivation of something that already exists that is typically 50 to 100% more expensive than the current products. There's also been a push and a call for fast tracking of the medication approval process, similar to what has been done in the United States. So I would argue that before we embark on this and before we take this drug shortage and turn it into, well, let's just make things accessible more quickly so that Canadians aren't hard done by and aren't dying because of access to medicine, let's look at what's happened in the United States with the fast-tracking legislation. And essentially, they have achieved their goal. They've gone from an average of slightly over 2 years for a drug to be approved down to approximately 6 months after this legislation was enacted. But there was a huge price to pay for fast-tracking and pushing drugs through the approval process much faster. And the price they paid is one of drug safety. And this is a study that was done by the National Health Institute, the NIH, that tracks medications as a function of when they were approved and what the rate at which they come off the market because of a safety signal. And you can see that prior to the enactment of the fast-tracking law, which is this time period here, the base rate was approximately between 1 to 2 drugs was taken off the market because of a safety concern after it had been approved. This is what happened when the drug went into effect. It went up to 5, in other words, almost a 2.5-fold increase. So the risk that we take by pushing drugs through too quickly or advocating for fast tracking is we run the risk that we don't have enough data about safety when they come up, and those risks are going to be borne by the Canadian public afterwards. In fact, if we compare Canadian and American data, my argument for not fast tracking in Canada is if you look at the list of medications that have been taken off the market in the United States, always because of a serious safety concern, almost all of these drugs were not yet approved in Canada by the time the FDA took them off the market. So I would argue that being slow and cautious is actually better for Canadian health than fast-tracking and increasing access. Finally, I want to talk a little bit about the dangers of aggressive marketing. And this is particularly relevant in the context of the news story that was on CBC this morning about the recent study in the CMAJ that essentially, using lots of modeling and assumptions and hypothetical scenario, has argued that national pharmacare, in other words, free drugs for all Canadians across the country, would actually be cost-effective and save upwards of $7 billion. And sorry, I didn't realize that it wouldn't come out. It comes out really well on my screen, but the projector screen is a bit blue. What I want to draw your attention to is the following. This sort of movie line here are drugs to treat attention deficit disorder. So these are drugs that predominantly children between the ages of about 5 to 10 years of age get prescribed for attention deficit, ADHD. The year after which the Ontario Drug Benefit Formulary, the list of medications that get covered for the population that's covered, tripled overnight. Within 1 year, prescriptions tripled. Okay, I'm going to hypothesize that it is medically inconceivable that we actually had 3-fold the number of children in this province untreated with true ADHD. And I'm going to propose to you that that is direct scientific evidence of overprescribing, overdiagnosis, and overtreatment. And only because the drug became available. So when studies get published that say that based on the Quebec experience, we're likely to see a marginal increase in drug use of 15% by making them available, I'm presenting you data that in a very vulnerable population, we have a 3-fold increase in the use of a drug that affects the mind whose long-term effect on cognition and behavior is completely unknown. And the sad part is that the risk-benefit ratio we accept as a society when a child is truly ill is completely different than the risk-benefit ratio of a child that maybe is just a little bit busy and society can't handle it or doesn't have the other non-pharmaceutical tools to deal with it. Thank you.
Dr. Evans, did you want to say something?
Oh, I'm happy to talk on the panel because I can,
Okay,
in
got
fact, a lot of the stuff Dr. Levésque talked about, I can give you the inside scoop on.
Okay, so then that's good then. So we're actually ahead of schedule. So what we're going to do right now is we're going to take about, let's say, 3 minutes, keep it to 5, where you guys can grab refreshments, come in. You had a lot of information that you need to break down, come back, and we're going to start a QA session. All right.